Hey guys, it's Dean from sciatica-relief-now.net, as well as Volk Physical Therapy and Sports Medicine in North Carolina, as well as Charleston, South Carolina. And I have the honor of interviewing Dr. Robert Watkins today. He is one of the most renowned orthopedic spine surgeons in the country. He is board certified in orthopedic spine. He is the co-director of Marina Spine Center and the chairman of surgery department at Marina Del Rey Hospital out in Marina Del Rey, California. So, Dr. Watkins, first of all, thanks for accepting the invitation to be interviewed, and I appreciate you taking time out of your schedule. If you can just give an introduction to yourself for my audience. Obviously, your audience knows you, but
yeah,
great.
You bet. Yeah, thanks for having me, Dean. So I'm an orthopedic spine surgeon, as you said, and in Los Angeles, Marina Del Rey. I work with my father, who's Robert Watkins III. My dad was probably the first spine surgeon to begin treating professional athletes to try and get them back to play a sport, really in the world, if not the country. And that was probably 35, 40 years ago. And he's taken care of Troy Aikman and Mario Lemieux, Wayne Gretzky, guys. And today, we kind of divide and conquer Los Angeles, at least. I take care of the Rams, the Dodgers, the Clippers. He does the USC athletic department, the LA Kings, and we help cover each other all the time, and the soccer teams and female basketball teams and the female athletic athletes at USC too. So we treat everybody from age 18 to 90 who has spine issues, cervical and thoracic and lumbar, basically fusions, microscopic surgeries, artificial disc replacements, all that. But the cool thing that I've gotten into the past couple of years is we developed an app called Back Doctor, which is a free app that's in the App Store. It has our whole rehab program that we treat athletes with. Is free, called Back. We've had 70,000 downloads of it in 2.5 years, which is amazing. I don't know who these people are. We don't charge any money. We don't collect any data. We just put it out there, and it's really cool to think that people all over the world may be helped with some back pain because of the app. And then we have a podcast channel called Dr. Robert Watkins, Back Doctor, 35 different podcasts on every topic you can imagine. And I just started Facebooking Live maybe 4 weeks ago, and now every time I'm even thinking about something in my head, I turn on Facebook Live and say it to the camera. And to me, the power, I think what you've touched on, the power is of being able to share information that we have with people who are struggling with issues. And information is free these days. You can just, if you want to know, you can go on YouTube, go on Facebook, you can get the information and help take care of yourself. And how cool it is that we've invested so much of our life into this topic, and we know so much that we kind of take for granted how much we know about these issues, and we think we got to do it one-on-one with a person. Well, no, you can record it out there, and you may help 50 people you've never even met in your life. And the power of that, I think, is just so cool. That it's my latest hobby for the past couple of years.
There you go. So you're a Facebook hobbyist, huh?
Yeah, exactly.
Awesome. So what is what's the most favorite part of your job as a spine surgeon?
Being a spine surgeon is awesome. I mean, I barely even talk about the surgeries because, I'm trying to help people with information of how to take care of themselves non-operatively. Like, what can they do on their own with our app and with diet, meditation, massage, cardio, what core exercises do? I think that's so cool. I'm 47. And so when I turned 40, I started having neck and back pain. And it was like, whoa, I got a physical job. I got to operate on people. This is a job of stamina and endurance. And so I changed the way I was doing triathlons. I stopped doing that. And I changed what I was doing to really focus on, I got to train for my job and for my life. And one of the benefits of our job is that we see people in pain all the time. And that's a constant reminder to us that we don't want to end up in pain. Because when you're in pain, life sucks. It doesn't matter how successful you are. You can be rich and famous and have a wonderful house all over the world, all this kind of stuff. If you're in pain, it's horrible. And so changing your lifestyle early to figure out how you're not going to end up in pain was part of why I started on this journey. And then realizing, oh yeah, all my friends are going through the same thing, and being able to share it with them because, they call you, hey, what should I do? And now I can just send them a link to my app and my podcast and say, hey, if you really want to know what to do, take 15 minutes to listen to this, and then you can do it all yourself. But the job itself, surgery is awesome. I love orthopedics. I love spine surgery. We use this computer navigated system. We put in screws. I put in 6 screws in a guy today who was really thick. His spine was here, and the fat and the muscle was about this thick. We did it through these stab incisions about this big with this computer navigation where we didn't have to expose everything. It's so beautiful and artistic and technically magnificent. That's amazingly fun, but it's kind of like another world. Tuesday and Thursday we're in this little hidden world of surgery, And the power of that, he woke up in the recovery room and said, hey, I feel good. Thank you so much. So that part of being a surgeon is so great, really physically doing things to people and on them and helping them. But then the other component of just sharing information, and then also the human component of interacting with people and the intimacy and the intensity of helping people with their lives. It's one of those jobs. If you get bored doing this job, well, you're bored with life, and you gotta figure out what you need to do to enjoy life at all, because this is as good as it gets.
That's awesome. You said something there that reminded me. I had an old office manager when I worked in Phoenix, who, when she turned 40, she looked at me. She goes, "Dean, when you turn 40, you're gonna have to learn something." I said, "What's that?" She goes, "You used to exercise for fun, and now you exercise so you can have fun." And
Right. Exactly.
And after I turned 50, it was like, oh my gosh, that's forever true.
Yeah. So true.
So as far as sciatica goes,
Yes.
what is your typical protocol for someone with sciatica, and what would you do as far as rehab versus surgery, and how do you distinguish, and what are the parameters that you look for?
Yeah. So sciatica, basically pain down the leg. How do we work it up? First of all, it comes into the history. How long have you had it? What brings it on? If it's sitting, going down the leg sitting, it's more likely a disc herniation, because the nerve is stretched when you're sitting and the disc can bulge out more when you're sitting, versus if you're standing, then it's more likely stenosis, which is more chronic, because when you stand, the spine closes down, cuts off the blood to the nerve, causes the pain down the leg, and the relief is bending forward, starting to walk, or eventually sitting down. So do that right there. You get it sitting, you get it standing, means disc herniation versus stenosis. So that's one of the questions. Then the other one, obviously, and I'll just give you our general things, and for people out there, on the physical exam, well, you got to find out, is the nerve working? Do they have any weakness? And is it a functional deficit? Do they have a foot drop? Do they have the weakness of their calf, their hip abductor, their quad? What exactly, do they have a neurologic deficit? Weakness is the big one. And then numbness, we also check numbness, check their reflexes. And then on the exam, there's a couple tests that we do. One is the sitting slump, sitting down, straighten their leg, have them sit up straight, just touch their chin down to the chest, because that puts the whole neurologic conductivity on tension. And if that irritates it, then it may be a disc herniation, or at least some type of nerve irritability. And then we lay them back supine, do a straight leg raise, and a popliteal cram test, where you stick your thumb into their popliteal, just next to the hamstring tendon, and push on the popliteal nerve as you straighten their leg, kind of bowstring test. If that causes the pain up and down the leg like they've been having, that's a pretty good sign of nerve irritability. And those are the big ones. I'll mention one other thing for technical details. Okay. The difference between a peroneal nerve palsy at your knee, affecting the peroneal nerve, causing a foot drop, and weakness of your extension of your big toe and dorsiflexion, versus an L5 radiculopathy from the back, you got to check their hip abductor, because their hip abductor is the L5 nerve. And if their hip abductor, lay them on their side, lift their leg up, push down on it. If it's weak, well, it's an L5 nerve problem, because it's coming from the back. But if it's intact and it's strong and it's just a foot drop, well, maybe their peroneal nerve. And you wouldn't believe how many people come out and see us from all over the country, and that hasn't been examined. And, it's a big part of determining, is this an L5 nerve problem or not? And that's what I explain to patients all the time. Sciatica, from a spine surgeon's perspective, I need to know, is this the L5 nerve or the S1 nerve? The L5 and the S1 nerves come out of the spine. They join together in the butt to make the sciatic nerve, goes through the piriformis, goes down, branches the peroneal and the tibial nerve in your leg. So when people talk about sciatica, for me, the first thing I say is, first of all, that's too general of a term. I need to know L5 nerve root or S1 nerve root, because, and they're just, they come out of the spine, they join together, they branch back out. It's just bundling of electrical wiring going down. When it's in your butt, we call it the sciatic nerve. When it's up higher, we call it L5 or S1 nerve roots. But for me, I'm going to do surgery on somebody. I better know which one it is, because those are two different nerves. Is it L5 or S1? And so on the exam, we want to pick up that neurologic deficit, see if they have nerve irritability, check their piriformis. We stick our thumb in their butt and check if their piriformis tendon is tender. And then check peripherally, check their pulses and check their reflexes, have them walk, range of motion of their back. So that's part of the workup. And then ultimately, when it comes to diagnostic tests, should I move on to that? The
Absolutely, go for it. You're on a roll. I love it.
when we move, yeah, you can tell I've talked about this before, huh? This is 10 people in my clinic tomorrow. Well, they'll have the same conversation with the first diagnostic test is X-rays, AP, lateral, flexion, extension X-rays of the back. The flexion extension X-rays only really spine surgeon orders those, because we want to see, is there instability there? Do you have a spondylolisthesis, some instability that's moving when you flex and extend? That changes the ballgame. If you've got instability, that's when we're talking about doing a fusion. If you don't, well, then we can do the microscopic little surgery we do on all the athletes, make a little room for the nerve. So we got to know is it stable or not, pretty early. And then an MRI is the next test. The MRI is an amazing test. It shows us three-dimensionally what's going on in the spine. You lay there, a magnet goes around your body, we get a three-dimensional picture, which is just a miracle. And so get that, see if there's any nerve compression going on. Now, a lot of MRIs can show some wear and tear at different levels, but we've got to nail down, does this correlate with where their symptoms and their pain and physical exam is? Because you don't just go operate on any bad MRI you get, you'd operate on everybody. You got to know, does this match? One of the great things about my dad is such a genius at making things simple. And he calls it what nerve, what level, what pathology. You do your exam, your history and physical, you pick up what nerve is the problem. Put it with one number, L4 or S1 or L5. What's the nerve? Then you look at the MRI and you figure out what level. Is it at L4, L5, L5, S1? And what exactly is the pathology? Put your finger on it. And is it a disc herniation in the foramen? Is it stenosis in the canal? Is it a slip? Really nail it, because that's the key to our job. And, these athletes, they come from all over the country and get opinions from us. In fact, my dad and I together, between the two of us today, have probably spoken to 5 teams and agents. Football's ramping up, baseball's getting down to the wire, and so we review cases all the time. They text us pictures. We kind of give them our opinion and look at it. And one of the things we really do is really just help process the decision-making of, have we checked everything? Do we know the source of the pain? And that's 80% of getting good results. If you're going to operate on somebody, well, first of all, you need to operate or not.
Right.
Number two is, if you're going to do the surgery, what's the least surgery you can possibly do and safely? Well, you got to know what the problem is so you can focus in on that and fix that and leave the rest alone. And one of the things that's beautiful about my dad is that he really has a great way of teaching, of nailing things down to what exactly is the problem. And that's huge. And then we get an EMG sometimes, a nerve test to check, is it peripheral nerve getting pinched, your sciatic nerve, your perineal nerve, versus is it coming from the back? So the EMG nerve test can help sometimes in the diagnosis. They're not greatly reliable, but they can help a little bit. Mm-hmm. It's mainly history, physical exam, MRI, and X-rays. Really we can tell 95% of people's problem with the combination of those 4 things.
That's awesome. I got a question. I've got quite a few people with piriformis syndrome that I've been helping.
Yeah.
And there is a doctor in the country who swears that piriformis syndrome, number 1, cannot be cured. The only way that it can be cured is if he removes the piriformis muscle. Now, as an orthopedic surgeon, what's your perspective on that?
I'd say it's 50-50. In my experience, patients who have had their piriformis released, it's 50-50 whether it helps them or not. And usually it's really a diagnosis of default. So if their back is normal, everything in the back is totally normal, it's not their back, and you push on their piriformis and it's tender and they have some nerve irritability, okay, maybe they got piriformis syndrome. Right. But I almost never recommend somebody has surgery, just because now the surgeries have changed. Mike Banfi is an orthopod at Curlin Job here in LA who does a scope. He does like an endoscopic type technique. He runs a scope up there. He says he can see the nerve, see a band across it, release the band through a tiny little incision. I haven't seen it yet. Huh. I want to go. I get something. As a surgeon, you got to go watch somebody do it sometimes, and I want to do that. But that sounds pretty interesting. One of the big keys to surgery is if your surgery really causes no harm. If you can do it so minimally invasive that you're not going to cause scar tissue, you're not going to cause a lot of pathology, but also you got to be able to do it safely. You got to be able to see the nerve and make sure you're cutting the band and not the nerve, obviously. Exactly. If you can do those things safely and reliably, well, that's pretty reasonable as an option if physical therapy and injections and everything else haven't helped for 6 months. And I have had some patients we've actually done surgery on, and then their back looks good. The nerves are open on the back. Maybe we fused them, solid fusion, everything looks good, and they still have this piriformis syndrome. So at times I've I've had at least 2 patients I can think of. We had piriformis releases after that situation. It did help, but I've definitely had a couple that it didn't help. And so my overall the results are 50-50, but Dr. Mike Banfield, I'll give a shout out to him. His technique sounds interesting, and kudos to him for, he's been in practice 15 years and he learned a new technique, and it may be effective.
Oh, that's awesome. Yeah, I was talking about not a release, but a piriformis removal surgery.
Yeah. Take the whole thing out.
Just cut it side to side, just remove it. And
that sounds a bit drastic.
It sounds, yes.
You know, one of the fun things I've enjoyed about Facebook Lives and podcasts is interviewing people.
Mm-hmm.
You know, we've got people in here in LA doing stem cell injections, giving people HGH and all sorts of stuff, and it's great to invite them to come talk. You know, if they've got a presence on social media and all Facebook, YouTube, all this kind of stuff, say, hey, well, come, let's sit down and talk about it, and really let's go over the science and say, does this make sense or not? And so it's a great forum for being able to share some information, and other people can watch. You know, it's like one of our medical conferences where people sometimes really go at it, and because we don't know the ultimate answer. And here's how we process. Here's how we make decisions. Here's how we go through the process. And I can tell you, ultimately, for me, I look every patient I take care of, and I tell them, look, if I had what you have, this is what I would do.
Right.
You know, to some degree, I can talk to you forever about all the pros and cons and stuff like that, but really it comes down to, would I have surgery or not? And what you alluded to before is, what do we do non-operatively? And we probably prescribe more physical therapy than any spine surgeon in history. You know, most spine surgeons, to kind of generalize, will say, well, you either need surgery or not. And if you don't need surgery, go somewhere else and they'll take care of you. If you end up getting a weak leg or a foot drop and you crawl back in here, then I'll operate on you.
Right.
You know, and for us, we direct the rehab. We tell them what to do non-operatively, and we direct it. And part of that's taking care of the athletes. You know, 95% of the athletes I treat, it's non-operative. Right. And so I go down to, you know, some of these teams, and they're in the middle of the season, and a guy's had back pain for 1 or 2 days. And I've got to tell them, okay, here we're going to do a steroid pack. We're going to do some anti-inflammatories. We're going to do an epidural if it doesn't get better. We're going to start the rehab now. Once you achieve our back stabilization program is 5 levels of strengthening. 1 is the easiest. It's neutral core stabilization, dead bugs. Lock your back in neutral. Don't provoke the pain, and work your way up more balance and coordination. But I tell them, you got to get to level 2. When you get to level 2, you can do non-impact cardio and start doing some rotator cuff exercises like throwing. When you get to level 3, you can start to throw the ball, hit off the tee, do rotational exercises. You got to get to a 4 before you really go all out and throw off a mound. And so based on our quantitative rehab program, which is on our app, is how we clear them to certain activities. But I'm directing that whole thing. You know, I mean, most spine surgeons are kind of like, hey, you either need surgery or not. For us, we've got to guide them all the way through. And so it makes a big difference in just the way we treat people.
No, that's awesome. So for the non-high-end athletes, say you just have somebody who's a weekend warrior, or a lot of people on my site are people who have been runners or have been trying to stay active. They have either piriformis or sciatica going on. What would be your best advice for anybody who is dealing with those types of problems, as a sort of, obviously this is obviously general,
right?
General perspective.
Yeah, and that's kind of what we were talking about before, is what am I doing now, you know, to live. My goal is to, every day I wake up and I'm not in pain, I'm happy. It's a good day. If you're breathing and you're not in pain, hey, savor it, because that's as good as it gets. And so I do cardio. I was telling you, I was doing some triathlons before. My crazy PA, my assistant, is an Ironman. So he got me doing these triathlons. So we were waking up at 5 in the morning and riding our bikes and swimming. My neck started hurting me. I was kind of like a little insane when you look back, but you know, maybe that was our midlife crisis. You know, it's like, just get out there and just try harder. And it was fun. We had a good time. But anyway, I started hurting myself. So what I do now is I basically do cardio. I do 30 minutes of cardio 4 to 5 days a week, low impact, and I diversify. Don't get stuck doing the same thing. I do an elliptical, a recumbent bike. I run on a treadmill, and I swim with a mask and a snorkel, so I don't have to turn my head. And I mix those things up. My goal is to get my heart rate up for 30 minutes, get my energy up, release endorphins, circulate my blood, wash out lactic acid. You know, but it's not to lose weight. That's what I tell everybody when they turn 40. You cannot eat what you did when you were 30 and work out twice as hard to stay the same weight. Your metabolism slows down. You are going to get fat. Mm-hmm. And so if you try and work out hard enough to lose the weight, you're going to hurt yourself. You're going to get tendonitis. You're going to tear your Achilles. You know, all my friends tear your rotator cuff, everything that happens to us. So you want to control your weight. you better control your diet. You have to stop eating bad carbs, period. And I'm not crazy about it. I don't believe in the Atkins diet. Like, you should eat fruits and vegetables. Those are natural. They're normal. Anything that grows in the ground, you can eat. I'm talking about pizza, donuts, processed carbs. And so It's pretty obvious. It's what we all know, but sometimes we get so complicated as to these new diets. I live in LA, man. There's a new diet every week. Like, don't be crazy. Just be normal. Do what normal people do. That's what my brother always says. Just be normal. Do what a normal person would do. Fruits and vegetables, balanced diet. But that's how you got to control your weight. Don't kid yourself. Your exercise is to feel better, get your energy up. You want to lose weight, do it with your diet. And then basically I get a massage once a week. I meditate for 30 minutes, any chance I get. That's one of my escapes. You to feel like you're anywhere in the world, let all the tension go in your body. And I do that probably 3 to 6 times a week. And then I do core exercises. On our app, I do a dead bug, I do a quadruped, and I do a standing dead bug. I do 3 core exercises, and I stretch. But 3 core exercises, I do those at least 3 days a week, where I'm at least engaging my core and firing. And that's, I've been doing great. I mean, I tell you, knock on wood, you never want to jinx yourself, but the past 3 to 4 years, my neck and back pain is really not affecting me from any functional perspective. It's pretty non-existent.
Awesome.
Yeah.
Well, I appreciate you taking the time. Very, very informative stuff. One question that I do have, because I have a lot of people on my site who have had a micro discectomy done, and then they have a reherniation. And they ask me, well, what keeps the disc in? And I always go, when they take the disc that's leaking out, there's a hole there. From a orthopedic surgeon's perspective, what do you see as far as reherniations? How long does it take for that the hole to scar over, or does it ever scar over?
Gotcha. So after a discectomy, what happens to the back of the disc? And everybody always asks this. So first of all, all we take out is the broken off piece of the disc. So we're not taking out more disc than is already injured and broken. So the incidence of developing back pain and needing a fusion after a micro discectomy is not higher if you have the discectomy versus if you don't, because you've hurt the disc. The disc got injured just from life.
Right.
So you're at some risk of having back pain and needing a fusion because that disc is injured. It's not increased with the microscopic discectomy. And the relevance of that, the extrapolation of that is that we're taking the piece that's already broken, and it's already non-functional. And that's one thing people don't quite understand. It's not like we're cutting a big hole in a normal disc. No, we're taking out the broken off piece. We're still saving 80 to 90% of it that's still intact. We don't disturb that part. Now, the hole in the back of the disc takes 6 weeks to heal. And there's no way to rush that. Our results in professional athletes, we've done about 100 of them, 89% made it back to play their professional sport after a micro discectomy, which is a pretty good number. The average was 5 months. And 50% made it back at 3 months. And so I know other surgeons in the country and stuff will tell people, oh, you'll be back in 6 weeks, because they're used to normal people. Most people back to a desk job after 5 days. We're talking about an athlete, their job, their life depends on this. It takes 6 weeks for the annulus to heal, then 6 weeks of rehab. Well, that's 3 months, like that. And that comes quickly. The fact that 50% have made it back at 3 months is kind of a miracle. If somebody makes it back in 3 months, you're like, damn, you put the work in. You really did. Kudos to you, because that means you did your rehab hardcore to make it back at 3 months. So that's one thing about expectations is really important. When you're early in your career, you almost want to set expectations too good. You want to be too optimistic and say, hey, you'll be back in no time. You'll be back in 6 weeks. Once you have some more experience, you don't want people to think, well, if you're not back at 3 months, something failed, or they failed, or so 3 to 6 months on average. Sutures, glue, stem cells, nothing has been shown to help the annulus heal faster. So we don't do any of that. And so we just give it time. Let the body heal. We start our core program 4 weeks post-op. First 4 weeks, just walk. When you walk, the core muscles fire. They start working on their own. That balance and coordination and neuromuscular control starts waking up on its own. Mm-hmm. At 4 weeks, we start our core program. And our whole core program is the spine starts in neutral. So you're going to just breathe, pick up your legs, march with your legs, and keep your core tight. And you're not going to stress the disc. And so it's more likely to let the annulus heal without causing a recurrent herniation. The incidence of a recurrent herniation is between 10 and 20%, which is not that big of a number, really. Now, granted, that's probably with a 10 to 15 year outcome. And maybe in 20, 30 years, it increases to 25, maybe even 30%. We lose track of patients. But overall, it's not that high. As far now, that 10 to 20% is people who need another surgery. And what I mean by that is maybe there's another 10 to 20% who get another herniation, but it's not bad enough to have another surgery. So it happens. The best way to prevent it is, and my point about that is the best way to prevent it is give your body time to heal. If you're not a professional athlete, you're just going back to your life. I look people in the eye now who are in their mid 40s or 50s, and I say, when can you play golf again? Yeah, you can play golf at 3 months if you're crazy. You get to level 4 of our program and you're 3 months and you're pain-free. You can play golf. What would I do? I'd wait 6. I would wait 6 months before doing anything because I never want to have a surgery again. I want this to be a one-timer. And you know what? Before you start a new activity, like starting to learn how to surf or new takes, wait a year. Give your body a year. Sometimes the human body just needs more time to heal. If we're smart, we're reasonable, we do what a normal person would do, give it time to heal, and most things will sort itself out.
Very good. All right. Well, again, I thank you for taking time. I look forward to, when I'm out in LA sometime, stopping by and seeing how your operation works in more ways than one. So
please do. Anytime. We're right here in Marina Del Rey. Just come out. You come watch us operate. It'll be a lot of fun.
Awesome. Sounds great. Thanks for your time.
You bet, buddy. Take care.